Hello, welcome to Nuclear Medicine Bone Scintigraphy, Part 7, and today's talk is on bone infection. So, this can be quite a tricky and confusing topic. This patient came with he came to the nuclear medicine department with a bone scintigram request because he had a raised PSA. I think his PSA was 25, and he had an irregular prostate on rectal examination. So the clinical suspicion was that he had prostate cancer, and they were looking for bone metastases. The patient did also have quite severe back pain, and he'd been investigated for that recently and had a CT scan. So this bone scan, things generally look okay, but of course I'm sure your eye is immediately drawn to this vague area of increased activity in the upper lumbar spine. And what's that? It doesn't look like classic degenerative change. It doesn't look like a wedge compression fracture, but of course there's no use in radiology in saying what things aren't. We've got to say what they are. So I suppose we might have thought about doing a plain film, or more likely a SPECT CT on this area, but the patient did actually have a recent CT scan, as I said, so I decided to have a look back at that. And here it is, and here we can see the sagittal reconstruction, which fortunately in our institution we print as standard, and you can see here the nice end plates at most levels. Nice inferior end plate here of L4, superior end plate of L5 surrounding the disc. The same here, but here you can see there's marked irregularity at the adjacent end plates, and we can see it here on the bone windows as well, and this appearance would be highly suspicious for discitis or septic discitis, infective discitis, spinal infection essentially. This is the classic appearance. Now, you can see this on plain films. They say about 3 weeks after the patient develops symptoms, and MRI is probably our investigation of choice because it allows us to identify the presence of any extradural abscess or extradural inflammatory mass or extension into the spinal canal, which might help us determine if drainage was necessary. But you will see these things incidentally or on bone scintigrams where patients are sent for back pain, query metastases, and you have to be able to recognize them. So there is no classic appearance on the scintigram, just this area of increased activity, but that's what it turned out to be in this case. Here's our MRI scan on the same patient. Of course, this is a more sensitive examination, giving us more information. There's some fluid here, probably in the disc space. This would probably be pus, extensive edema in the bone marrow on this fat-suppressed T2 weighted image, and bulging of the posterior longitudinal ligament here into the spinal canal. T1 weighted image here demonstrating signal loss. Here's another patient who was coming for prostate cancer assessment, and they actually had no significant symptoms in their back, but they showed this area of increased activity, which just looks very strange really. It's based around the disc, or is it based around the center of a vertebra? It's hard to know really, but we decided to get a plain radiograph on the patient because this was many years ago when we didn't have a SPECT CT machine. And here we are. That again, the same thing, the same findings that we look for on a CT scan, we can also look for on a plain radiograph. So the cardinal sign of infective discitis or septic discitis is irregularity of the end plates. This patient has lovely smooth end plates here. You can see these are nice and normal, but there's extensive destruction of the end plates here, correlating to the site of the abnormality. There isn't really much fluid in the disc here on MRI. There is some sort of edema or some kind of change in this adjacent bone marrow here, but the patient didn't have many symptoms, so this was assumed to be chronic discitis, and in fact on follow-up MRI it didn't change very much, so no biopsy was performed. You can see widespread bone infection sometimes, especially in immunocompromised patients. This is a patient with leukemia who had fevers and multiple joint pains throughout their body. Bone pain at multiple sites throughout their body, and a bone scintigram revealed multiple focal areas of uptake in the mandible, humeri, forearms, femora, and tibiae. We did a few x-rays on the patient, and you can see some sclerosis here in the tibia, and this area was felt to be the most appropriate site for a biopsy to see what was going on, and they did have a biopsy of this area using CT, and it actually grew E. coli. So this patient had E. coli osteomyelitis, which is quite unusual, but of course any organism can occur in a very immunocompromised patient. So you can see widespread bone sepsis on bone scintigraphy sometimes. Sometimes the clinicians will request it if the patient has multiple blood cultures which are positive and they can't find the source. Okay, so we're going to move on now to talk about what we call a three-phase bone scan. So back in the very first talk I mentioned that the distribution of the tracer is proportionate to the blood flow to a particular region, and therefore we might benefit from examining the patient in the early phases immediately after injection, or just 5, 10, 15 minutes after injection, to see if there's an inflammatory process in the soft tissues. So essentially this is like an angiogram. We've examined the patient's pelvis and upper thighs, and we can see the tracer is injected here. We've started the scan, and at 15 seconds you can see the tracer coming down the aorta, both iliac arteries, and into the femoral arteries. And shortly after that, some is building up in the soft tissues. That's called the vascular phase, and this is an anterior image of the patient hips. We're looking for loosening or infection in the patient's hip replacements. Here we've got anterior and posterior, what we call blood pool phases, 1 minute, 5 minute, 10 minute views. This is actually going to be the uterus here, perfusion of the uterus. This is the bladder, and this is just some perineal soft tissue. So here we can just about see the photopenic defects from our hip replacements. These are normal. And here we see our classic delayed image, just as we've been seeing before, spot views of the pelvis demonstrating very low level activity in the margins of both hip replacements. So this is a nice normal appearance. And it's said that the activity around the replacement should be the same or less as the adjacent iliac wing. This dark area here in the lateral view, which we've done, is just due to the activity in the bladder. And here's a patient with, we're looking at their knees. This is a patient with with infection of their right total knee replacement. The early vascular phase demonstrates increased activity around the knee joint here. We can also see that on the blood pool image here. These are the anterior and posterior blood pool images. And you can see there's accumulation in bone as well on the delayed phase. So it's always difficult to work out if this is due to loosening or infection, but in this case the patient had septic arthritis of the knee replacement. Here's a patient with an infected total hip replacement. Slightly unusual appearance here. The acetabular region is normal and the infection has only showed increased activity in this area, but this can occur, and this was proven by aspiration of the joint. Now we can also image patients for chronic infection. This is a patient with suspected chronic osteomyelitis. The vascular and the blood pool phase here is showing increased activity in the right distal femur. We've done a whole body examination here. This is the delayed phase showing increased activity. And we've done a SPECT CT here. You can do SPECT CT in the hip or the knee replacements, especially if you have a CT scanner with metal artifact reducing features, but often it's not that good because of the artifact from the metalwork. We try and do these routinely in patients with chronic osteomyelitis, especially where the metalwork has been removed, because we might be able to see things like sequestra or cloacae or abscesses around the bone. So here's a dense focus of bone, which may be a sequestrum. There's quite a lot of activity here, obviously. The patient had pain, so it was decided to perform a biopsy, see if any culture could be obtained. It's often very difficult to obtain a culture of the organism in chronic osteomyelitis. Here we are, the surgeon is preparing for their biopsy, and they did indeed perform a biopsy, but unfortunately no organism grew, and the patient hasn't had further investigation for two reasons. One, because they're feeling quite well, possibly due to the fact that the bone has been decompressed during the biopsy. They got a sudden improvement in their symptoms, but also they're not being investigated further because they're feeling okay and we're in the middle of the COVID-19 pandemic. So this is the sort of appearance that you might see in chronic osteomyelitis, and this is how bone scintigraphy with SPECT CT can be useful to assess the extent of any activity and decide if further invasive tests are worthwhile. Okay, so I think we'll call it a day there, and in the next part we'll just look at a few miscellaneous SPECT CT scans. Thank you.